Dear Pure Urology viewers, good evening one and all. Today, as you all know, Pure Urology is based on surgical techniques. Today we are discussing TURP. For all the seniors, TURP may be a small surgery, but every junior has to start with a gold standard for prostate TURP surgery. As the time goes on, when we were PGs, we in 2005, not far before, we have not seen open surgery. We have done TURP, but unfortunately, camera was not that much used. It was used, laparoscopy, but not for TURP. Then now cameras are there, but cases are not there. You understand what I point? That the cases are not there. The boss or assistant professor will do it. The junior will be seeing, but he has not done it. Once he passes MCH, when he goes to the private practice, he doesn't know how to do it, but he can do it. Honestly, I must tell you, if you pass cystoscope and don't do anything and come out, still patient will pass urine. But that's not the aim. You have gone intent of relieving obstruction with prostate removal. You have TURP, you have bipolar TURP, you have enucleation, and you have lot other surgery like mist. But what is the gold standard is TURP. Now in TURP, if a small gland is there, anybody can manage because seniors, they will teach, you will do it. But if the large gland is there, 80 grams, sometimes even I faced a problem in the early period that when you are cutting, bleeding happens and you will stop in between and put Foley's catheter and come out. What will you tell the patients? The gland is still there. You have not done justice to the patient. These problems will be there. To discuss about that, very senior urologist from Bangalore, Dr. C.S. Ratkal sir. The time I'm little emotional in the live Pure. I'm saying that my mother-in-law, who is a doctor, used to say about Ratkal sir because my mother-in-law's mother worked as matern in hospital where Ratkal sir has worked for 30 years. So let us listen from Dr. C.S. Ratkal sir from Bengaluru, how I will interview him how the different clinical scenarios you will face the problem, especially tier 2, tier 3 cities. When the problem goes on, you will be under stress. What should you do? What is hyponatremia? All this we will discuss detail today. So I will share first sir's CV and then I will go for the pure talk. So today topic is simplest topic. Some seniors say, what is this nonsense he is doing TURP? No. For every junior, when he is born, he is junior. Generations will come where TURP will be the gold standard. You should learn. So to speak about that, Dr. Chandrasekhar Ratkal is a chief consultant and rescue hospital, Bangalore. He has 38 years of clinical experience in urology. He did MBBS from Karnataka Medical College, Hubli. He completed MBBS from MS General Surgery, Mysore Medical College. This is called MMS, famous medical college. He obtained MCS from Bangalore Medical College, BMC. Former Director and Professor of Urology, Institute of Nephrology and Urology, INU. He was the past President of Association of Southern Urologists, ASU. I am presently Secretary of the ASU, Honorary Secretary of ASU. He was the past Council Member of USI 2021 to 23, Urology Society of India. He worked as past President of Karnataka Urology Association and Bangalore Urology Society. Expertise in reconstructive urology, RIRS and laparoscopy. He used to say that, Chandramohan, I will come one day and learn RIRS and I will practice. But before that, he learned. That is his attitude. Now coming to the topic, Sir Ratkal sir, very,
Good
very good
afternoon.
evening. I thank you once again for giving the opportunity to interview. Welcome, sir. Thank you very much. Now, sir, I want to ask you first question.
Okay.
In your MCH days, TURP is done with camera or without camera?
Without camera.
Then tell me honestly, what will you see, sir?
Nothing.
Nothing. After finishing MCH, did you work in any institute?
No. Only in my institute where I
Why
continue to be
institute?
assistant.
Then when you taken a first case, did you do with camera or with eyes?
Eyes. There's no camera.
There is no camera. In which year it is, sir?
No, from 1990 I started my TRPs on my
No,
own.
sir. Which year you passed your MCH?
1989.
So 1989, I was in intermediate. Matlab, even I have not started MBBS. So I want to ask you, who is your main teacher, sir?
Our Professor HOD was Annamalai.
Huh?
Annamalai. A.K. Annamalai.
A.K. Annamalai. In my MCH PGI urology, Dr. S.K. Sharma used to do without camera. He resects large glands with both eyes open. You know, when you see in the blue, he doesn't close one eye. We used to be talk about the very important about that. If you don't see, did your anomalizer has shown you how you resect in between when he is doing?
Hardly anything we could see.
Hardly anything. So how will you understand at that time? Let us go into the history.
First
That
of
how
all,
will
to
you
tell
understand what is prostate, how it looks endoscopically, how the loop moves, passive loop, active loop. There are two loops. I don't know what loop you are using. When you loop, you pull. It's a simple surgery. Anybody can learn. I am not saying it's a very difficult surgery like radical prostatectomy or partial nephrectomy. But without seeing all the seniors like you, after going to private practice, taken the scope and started, how will you do that?
Yeah. See, there is one very senior doctor at Pune, S.S. Bapat.
Yes, sir.
I used to attend his workshops.
Okay.
And also he has brought out a video book.
Okay.
I used to see his videos before any case I posted for surgery because most of my TRP I learnt in private only. Because we didn't have any facility to do TRP in Victoria Hospital.
Okay. Yeah, Victoria Hospital.
I learned it from him and attending his workshop and also looking into.
He is the same Bapat who is Ratna Hospital.
Yes, yes, yes. Same.
Yeah, he was the one my examiner in DNB.
Yeah.
I asked.
Great teacher.
Great. I fortunately got gold medal. That's a different issue. Great teacher. And one thing I wanted to tell you, sir. If you are taking in private practice prostate, will you assess the prostate size by ultrasound or by rectal examination?
Mainly, I used to depend on rectal examination, and I used to definitely supplement that with ultrasound reports also.
Sir, in rectal examination,
and finally cystoscopy.
What is the warning signal when you do put in your finger in the rectum? What is the warning signal that you may have problem today? It's a big bulge.
Very big prostate where I could not reach the upper limit at all. In those cases, I always used to be very, very cautious.
Correct. Sir, honestly, I am telling you, at that time in 1990, when you are doing TURP in Victoria Hospital, is the blood reserved?
Yeah, that time we always used to reserve. Because that time TURP bleeding was a concern.
Now we don't reserve.
No, not at all. We don't even do cross matching.
So, dear friends, if you are in the beginning part of your career, there is no harm in reserving the blood.
Agree that point.
Reserving and getting the blood is different. Reserving is telling the bank that I want 1 unit, O negative or O positive. In case required, please give me. I will pay money. All nursing home owners, especially in tier 2, tier 3 cities, must say that O negative or A negative, AB positive should be reserved. But
Yes.
in the present era of a new cautery, new lasers, a bipolar cautery, you don't may not require it, but reserve at least more than 80 grams of prostate. Do you agree, sir?
Yeah, I follow that.
I
Not
follow.
only that, big gland where I expect patient you who are on blood thinners. Those
Yeah.
cases I
See,
always
sir,
anticipate
do
bleeding.
you accept Ratkal, sir? After stopping 5 days of aspirin clopidogrel, also some amount of oozing will there in these patients.
Yeah, it is. It is there, but usually it has not caused me more problems at all.
More problems. So, if you are in doubt, arrange the blood. Do you agree, sir?
Yeah,
Yeah,
100% agree.
agree. Sir, next thing, many times we see ultrasound saying 100 grams, 120, 200, 300. When you reject and weigh, I used to buy that Goldsmith
Was
weighing
there
machine.
with us
When
also?
you weigh, it will be 60 to 70 gram. I'll say 120. I might have rejected up to the capsule, but I feel bad that only 60 grams will be there. Is it true that you have to reject only transitional zone of 60 grams is enough or not?
That is enough.
Enough.
Definitely what we reject, because that is a on-table decision. We have to look into the fossa, whether adequate fossa has been created, whether the passage is very good. Of course, it is a must. You must go up to the capsule. Definitely resecting only the that part, median lobe, which are the part of the adenoma only, is the standard of practice.
So, transitional zone adenoma resection leaving a good channel is enough.
Enough.
Don't try to do perforation of the capsule multiple
No.
places. Don't try to do too much. You agree, sir?
100%. But you
100%.
have to reach the capsule. But
You
whatever
have to
false
reach the
capsule,
capsule. I
that is a
understand.
must. You
But
can't leave any tissue behind.
don't perforate repeatedly.
Yeah. Not even
Sir,
once.
I
Not even
want to
once.
ask you a question. In your beginning area in Victoria or in your training period, is the water used anytime, sir?
See, yeah. I have myself used even in private practice.
Water?
Water.
We have not used. Did you use water?
Yeah, I have used it.
The
Because
people say
there is,
vision will be very
there,
beautiful with
there is
water.
one Patil, Dilip Patil used to come to me when I was doing some dissections. When our big gland is there, I used to take. He was trained at Mumbai. He was very good.
Very
So
good, sir.
yeah.
He is a urologist. He is a
Dilip
urologist.
Patil, who worked in the Satya Sai Hospital.
Oh, very good.
Dr. Dilip Patil. He worked recently NH at Mysore. Now he has come back to Bangalore. Dilip Patil.
Okay.
Probably you have heard.
Yeah,
So
yeah. Dilip
he was
Patil, sir, in
advising.
Satyasai, I know.
Yeah, he was very fond of only RO water using for TRP.
RO water they used to keep in steel plant and then
Yeah. I have my steel plant.
open steel plant.
Yeah. That steel plant is still there with me.
Oh my God! I want to see that photo. We have 3 liter saline bottle.
Yes. We used to pour the
People
water
used
in
to
that.
pour in the
Yeah,
steel
that is
plant.
there with me. I used to connect my pipe to that and use. It was open.
That time TUR set is not there.
TR set was not there.
What was there? IV set.
Pipes.
Pipe.
Yeah.
How much is the cost of that pipe and all that?
That was very nominal. I don't remember
100
exactly.
rupees, 200 rupees.
Maybe that's all.
Sir, tell me honestly, TURP at the first TURP, how much you have charged? Tell truly.
1,500, 2,000?
How much profit you might have got?
Hardly anything. If
Thoda,
you calculate, see, Chandramohan,
sir,
see, I was learning
sir.
on
Because
a
people
patient.
say now I am doing for 30,000, I am not getting any profit.
No.
How you should think like that?
Shall I tell you? I used to cystoscopy for 100 rupees.
That is the rupee value, no, sir.
Take all my instrument, do the cystoscopy and come back. But I used to charge only 100 rupees. This I am telling 90, around 91. And
Really
TRP maximum around
1991,
1,500
in 1991 Bangalore, What is the
Yes.
charges of TURP in private practice? Average.
Private practice, I don't know others.
You used to charge
I used
1500?
to charge only around 2000 rupees.
Oh, so the rupee value goes
And
down. I
I
mean,
remember very well one VIU I did on 1000 rupees.
oh my God.
I remember
We
still.
can't imagine 1000 rupees now TUR set is not coming. Anyway,
So,
sir, next
because
question I want to ask you.
why I tell you why I was
Sir,
doing like, because I was learning from the patients.
okay.
I had to pass on this
You are
benefit to
very
the patient.
honest.
I had to
So, dear,
pass on the benefit to the patients because that
dear
patient is submitting
juniors,
me to learn the procedure.
yeah, dear juniors, take this point very important. I am very emotional about this point. Very, very emotional. When I purchased the Mantra Robo, when you do vesicovaginal fistula, don't look at the charges. You are learning on the. So what sir told is very, very, very important. In future, like in UK and US, patients will not be there. Everything will be on practicing modules for which you are paying. You go to a workshop on a module to pay 15,000 rupees. Respect that for the patient. I am also private practitioner. I have also hospitals. But when you are doing, for example, if I am doing radical prostatectomy for advanced disease, you also learning. Don't miss this point. Next, sir, when you start the TURP, as of today, monopolar versus bipolar. Sir, sorry to say, I do monopolar very well today also. I have monopolar, bipolar, enucleation, TFL, 160 watts also. No hype. But when you cut with monopolar, sir, it has a good coagulation effect. But you are doing, I have seen your videos, you are doing bipolar. How many years you have done monopolar? How many years you have done bipolar from 1991?
Yeah, till 2010,
Sir,
I had done monopolar only.
2010.
10.
Okay. Yeah, after 2010, you switched to
I
bipolar?
started bipolar slowly. But when I started bipolar, I was finding the way I used to, that speed, I had to cut down with bipolar.
Yes.
But
Yes,
monopolar,
sir.
I used to be very fast.
Monopolar is very fast because I'm not telling you, sir, my experience.
Yes,
It
yes.
cuts and coagulates both. Whereas monopolar cuts, but coagulation is little less bipolar. Do you agree, sir? Bipolar coagulation is less.
Definitely. That is
Definitely. Sir, next question. For juniors, they don't look about Nesbit, X, Y, Z procedures for various reasons. I am not pointing out the teaching, but they want TURP to be done. Honestly, when you go inside, you will see the prostate. Any urologist will see the prostate. Will you start at the 6 o'clock median lobe, 9 o'clock, 3 o'clock, 12 o'clock? Your loop is ready. Your cautery is ready. Your monopolar bipolar is ready. Where will you cut first cut?
See,
6, 3, 9, 12.
as soon as I do the cystoscopy, I assess the length of the urethra.
Okay.
That is very important for me.
Sir.
So I will study the glands anatomy very well at 12 o'clock, 3 o'clock, 9 o'clock. Everywhere I study it very carefully.
Sir.
If there is a median lobe, even small median lobe is there, I will start at 6 o'clock. If there is nothing, there is no median lobe at all, then I will start at either 11 o'clock or 1 o'clock.
Okay.
That is my practice.
Sir,
Leaving 12
if the
o'clock
median lobe is there, first you will reject median lobe. Why?
Always. Because there are two reasons. One is obstruction to the scope is taken away, and irrigation will be much better once you resect the median lobe.
Okay.
Even there also we have to be very careful. As far as possible, around 70-80% of the median lobe should be resected. we should
Do you
leave
mean
some
that
tissue.
when you are resecting median lobe, you will not go and perforate the capsule?
No, not at all. We have to keep, because that is the one worst complication which can happen. Once you undermine the trigonal area, we will have a lot of problems.
That means you say that don't be over aggressive to make undermine, and every time your scope goes, you will be making a hole.
Going inside
You will be
only.
making a
That
hole.
that
You will
will
be
cause
making a hole in the 6 o'clock.
lot
It's
of
not good.
extraction.
It's not good.
Not at all good. That's why leave some tissue. Final at the when you are doing final touch, that time you can definitely
Sir,
do that.
this is the, I feel this is the most important point for the juniors. For your kind information, 127 people are watching your video. Is a golden point that don't try to be too perfectionist in the beginning. Go into the capsule at the median lobe, leave some gland, play on the platform, go to sites and do last May. If you feel that you want something, do a small resection, but don't perforate in the beginning, because your scope always hits on the floor and you perforate during evacuation of the fragments. You agree, sir?
Yeah, that is the point.
The point. This is the point.
Because initially you will be in trouble if you are over aggressive.
Yes, sir. Sir, next question. When you do a resectoscope, will you go step by step, bladder neck, middle of the gland, then veru, or in the floor you start entire thing from bladder neck to the veru? What do you prefer?
No, in the floor I definitely go till the veru. Only
Okay.
little mucosal tissue I leave there in the
Okay.
floor. But when I come to the lateral glands,
You will go first to
exactly,
bladder neck.
yeah, first bladder neck area, that proximal part of the gland. You say
Second question, sir. When if you cut, some people, seniors who are overconfident or experienced, they cut fast till even the bleeder is there. What is the message you want to give, junior? Sputter is there, you will spot, coagulate and then start, or you will cut and then do that?
No. I will not take that chance. Wherever area I have cut, I will look for the bladder, I coagulate, then only I will proceed. Because that is the best way. If the vision is obstructed, we will be in more trouble. That's why I always see that, especially Nesbit technique, mainly I use Nesbit technique. You get very good vessels at the bladder neck area. Once you coagulate them, most of the bleeding should be under control. Almost with loop, I can enucleate the gland, put it on the floor.
Correct.
Both side I do, both.
So, dear friends, irrespective of your experience, I also opine with, even though I am not experienced as much as Ratkal sir, I am also 22 years in urology, that when you cut any bleeder major is there, coagulate and then cut, coagulate, cut, no problem. 1 minute it will delay, but later 5 and 7 o'clock will become completely coagulated and the gland becomes avascular and you can cut faster later. So first bladder neck region, coagulate, cut, coagulate, cut, coagulate, cut. You agree, sir?
Yeah. See, once you do that Nesbit technique, mainly at the bladder neck area, at 5 o'clock, 7 o'clock, you get those major vessels. Once you coagulate and resect at 9 o'clock and that 11 o'clock and 1 o'clock area and make the gland fall, it will be completely avascular gland, blanched gland.
Yes,
you will not get any bleeding.
Yes, sir.
Then you can be very fast.
Sir, one question I want to ask you, sir. Don't think it's a company favor. In 1991, which resectoscope you used? In 2000, which resectoscope you used? In 2025, which 26 by is the first one, 24 by 22 is next one. How did you change your practice style?
No. From the beginning, I have used stores. It is very friendly.
Sturdy. I also use Sturdy.
I have also used Wolf sometimes.
Wolf also good.
Only as a demo. I'm not at all comfortable. I'm very comfortable with Stores instruments. They are sturdy, durable, and very good. We are not promoting any company. But
I am also not promoting any company. It is a open
even
forum.
Today I have only Stores.
I also only Stores. But when I use 24 by 22, I feel Wolf is good. because it is a working element
Yeah.
for laser also.
Yeah, that is-
Don't mind, sir.
Yeah.
My opinion, I am telling.
I have that endocyst.
You have yesterday you told that 24 by 22 is also should be there in your theater.
Yes, it is
Do you
there.
have, sir?
Yeah, I have, because I am not, if you didn't come to that, I don't use notice. I am not used even once
I
in
will
my
ask
life.
the question, sir.
Yeah.
Sir, I want to ask you, if the penis is small, if you are doing 50 grams prostate, if the urethral meatus is small, if 26 French is not going, I do otis, I put lot of jelly, I put 26 or 24. What will you do, sir?
See, even earlier, sometimes I was practicing the dorsal cut of
Otis.
the meatus. No, not notice. Just I
Dorsal
used to use
cut of the
knife.
meatus.
Meatus, only meatus.
Dorsal cut.
But that also I stopped because I am not very happy with that also. Now I have meatal dilator which I'll use, that's all. Not the complete urethral dilatation. I use only meatal dilator.
Sir, in Chandigarh, when I did my MCH, Dr. Goswami sir used to tell that after doing TURP, after 2 weeks or 1 month, call for calibration.
Yeah.
Do cystoscopy, assess the urethra, tell if any damage is there, respect the urethra and protect the urethra. Do you agree for that?
Yeah, that is my practice today also.
Oh.
Post TRP, I'll call them for calibration and I use 14 from CIC catheter. I calibrate them every month for 5-6 months so that they should not go for stricture formation. See, whatever it may be, whatever instrument you use, we don't know still what is the cause of post TRP strictures. It is better to prevent by this before the fibrinous stage goes to fibrous stage.
Yes.
If you practice this,
yes.
if in fibrinous stage, if you dilate the urethra, calibrate the urethra, you can prevent 90% of the strictures.
So, dear urologists, juniors who are watching, I must tell that calling after 10 days, doing freely cystoscopy, doing gentle OIU, free of cost, with Zalocan jelly under local anesthesia, release the adhesions, will prevent major morbidity to the patient. We have been trained, science has proved, and Ratkal sir is also saying, if you feel that you have done in a tight urethra, please call after 15 days, 1 month, do cystoscopy with 15 French, see that the urethra is normal or not. If required, do gentle OIU or dilatation. Ask them to follow up, will save lot. Do you agree, sir?
Yeah, I agree. Even one point I want to tell,
Sir.
whether it is a narrow urethra or a good urethra.
Sir.
Because as you know, we don't know the cause of post-TRP stricture.
Yes.
There are many theories.
Yes.
That's why I even don't do cystoscopy, nothing. I just call them, do a gentle, nicely put jelly, do a gentle calibration with 14 French CIC catheter. Yeah. If that goes easily, and after passing, and after that, what I'll do, I'll tell you, I fill up the bladder. Yeah. I put the 14 French, no, I fill up the bladder, ask him to go and wide. Correct. And his flow is good. I'm happy.
Dear friends, I am speaking from my heart that don't do blind dilatation. What sir is saying is that 14 French catheter if goes freely.
CIC.
Be happy. Give time for his widening. See the widening. Leave him. But if you do blind dilatation, you may cause trauma, bleeding, worsening of that flimsy stricture. That's not good. You are harming. So please don't do that. I strongly disbelieve. I don't believe in dilatation blindly in the era of 2025. Take a 15 French scope or Foley's catheter, pass it. If it is going easily, for God's sake, leave him. What do you say, sir?
Yeah. See, to extend it. Now, even post VIU, I will call them and do only just calibration with 40 CS catheter.
I strongly agree.
I am not doing, I was very great in favor of dilatations with almost my distals are now thrown into corner.
Dilatation is blind. Any
Completely
blind
banned.
procedure,
I have completely stopped it.
I have completely stopped it. So, juniors, if you have benefit of doubt, the idea of this pure urology is if a 38 years consultant is saying that I have stopped dilatation, if the world literature is saying stop dilatation, if I am also saying stop dilatation, think once again that you also see only cystoscopy or calibration with Xeloc and jelly. But don't do blindly putting a rod, putting here and there,
Very harmful.
making a false cannula, bleeding, making a simple flimsy stricture into a complicated stricture. Don't do that. Don't do that. Now, next, sir, I want to ask you, will you use loop? How many times the loop comes for TURP? I use for 4-5 times. It is costing around 2000. For each case, it will cost 500 rupees. Cost effective. Indian loops are okay. What is your opinion?
Yeah, I agree with that point. But big glands, sometimes I need one loop completely. Even sometimes I have to use two loops also. But otherwise, small glands, one loop we can use for 3 to 4 cases.
Yeah. Small glands, one use.
I also use
Large
Indian.
gland, don't worry. One loop, if it gets damaged,
Doesn't matter.
use the new loop, finish it properly and
Yeah,
go.
yeah. That's why I
Sir,
always insist.
one more important question I want to ask. You have done slowly bladder neck. Initially, we feel very happy. Nicely we are doing. Slowly bleeding starts. You cut fast here and there, then bleeding increases. Then vision decreases. Still you continue here and there. Somehow you will be after 30 minutes, you feel that something is not going happily. Two reasons. One is gland size is big, vascular, aspirin, clopidogrel, whatever it may be. Tell me honestly how you manage this case.
Yeah.
This is very important question, sir.
Yes.
How you manage after half an hour if the bleeding is there?
See, whenever there is disproportionate bleeding after my resection, I will first look at the monitor.
Yes.
What is the BP of the patient?
Okay.
If it is at higher side, I will request my anesthetist to bring down it.
Excellent
There
point.
was a time they used to tell hypotensive TRP.
Yes, sir.
Isn't it? They were doing some patients. So first thing I will look at the BP of the patient. If that is brought down, my 50% the problem will be solved.
Yes, sir.
And if there is any need, I will ask the person to increase the irrigation, taking it little high, so that I can
correct.
see if there are sputters, arterial bleeders are the only major issue for us. Once you take care of the arterial bleeders, everything will be fine.
Sir, do you agree that go systematically from floor to side from bladder neck, see the bleeders, coagulate, and then restart. Don't do again cutting. Stop it, coagulate. You agree, sir?
Yeah, definitely. You have to achieve hemostasis. Unless you have good vision, what can you do there?
Yeah.
Nothing.
Nothing.
Good vision is always good, but you have to be very systematic. You must remember where you have cut. Then only you will know from where bleeding is coming.
Sir, do you think that the surgeon should have a 3-dimensional map from vein to bladder neck? Every time when he is cutting, you should know where he is cutting.
Yes, yes.
5, 6, 7, you should tell. Blindly, you should not cut.
No. You should not here, there. You should not go like that. Wherever you cut, confirm you are totally good hemostasis, then only go to the other field.
Yes, sir. Sir, one more question. In the mid part of the gland, when you are cutting right side, left side, sometimes two big gland will be there. Honestly, tell me, every part has to be seen capsule or thoda little compromise is okay?
No. I think reaching the capsule is the most important thing.
Sir.
So as long as you correctly do the Nesbitt technique, slowly starting at, suppose you start at 11 o'clock, then come to the 3 o'clock, like that, if you do correctly, I think most of the gland will fall in the floor and it will be almost avascular gland. So you will not have any problem. No question of leaving any tissue as much as possible.
So, dear friends, capsule is the landmark. What sir is saying is that whether it is at the bladder neck, whether it is at the mid-prostate gland, whether it is Veru, have landmark capsule, try to go nearer to the capsule, resect as much as tissue so that it's not the completion of the TURP, it gives less bleeding because at that level all major bleeders are coagulated. You agree, sir?
Yeah,
Yeah.
definitely.
Sir, next question I want to ask you.
Even tell you this pregnancy hemorrhage, what they call it as. Once the baby is delivered, bleeding will stop automatically.
Yeah. Sir, even I am telling you, sir, in nephrectomy or in hysterectomy or in cystectomy, once the specimen out, bleeding stops, sir.
Yes, that's what.
So
Same
quickly
principle you have to think of here.
in destructive
Unless you remove
surgeries,
complete gland, you will not
yeah,
control the bleeding.
yes, in destructive surgeries, quickly take out the specimen by sometimes by hook or crook, I must say. If you moment you take out the specimen, the renal fossa becomes absolutely dry. But if you keep the large kidney hanging, one drop, one drop, one drop will be coming. Finish it. Fast you take out once the renal artery and vein is over. Don't keep on hanging at the other areas. You have to be little quick. Once the bladder neck is over, quickly go to the middle area, quickly go to the Veru region. Next question, sir. Lot of present patients are on dutasteride. They come after 2-3 years. If the patient is on dutasteride, when you do TURP, you see some fluffy gland and you have less vascular gland. You feel happy to cut, but large gland. Do you observe the same thing or any different?
Yeah, I definitely agree. Definitely, glands will be more avascular. Bleeding is much less patient. Even patient who have come to me with acute retention, if they are not taking dutasteride, even before starting resection, I put them on dutasteride and give at
Even
least
I
1
put
week.
on dutasteride BD.
Correct. I do one.
Post-op also I put on BD for 4 days.
Yeah, that I don't
Because
do.
there is a study that in 48 hours, 30% of vascularity comes down with dutasteride.
Correct.
Good na, sir. It's a good na, sir.
Yeah, definitely. There's no harm.
Sir, one more question. When you see a gland beyond the Veru, first phase in the first year, second year of post MCH, we will leave it. Patient will pass urine. After 5 years, we will go beyond Veru. Patient will pass urine. After 10 years, we go again back, leaving little beyond Veru. What is correct, sir?
Yeah.
Beyond Veru, if the large gland is there, cut it. If small gland is there, what to do, sir?
Yeah. This discussion in 1990, when I attended a workshop at Pune, Bapat conducted workshop.
Sir.
They were telling you have to resect that gland. You have to make the Veru float. But if float, this is the word they used to use, 1990 float. Workshop.
But incontinence will be there, na, sir?
Yeah. So no, I'll come to that point. Sir. That's why now that concept I don't agree. If you make float, definitely patient will go for incontinence. That's why I don't do that. We have to do resection, but very carefully. It is a very highly technical resection. Small. And you will see that contractions of the sphincter. Once you see that, you stop that level. You should not go beyond that point. That is the most important thing. And another landmark is prostatic calculi.
Yeah.
That is another landmark where you have to
stop. You are in a good plane.
Yes.
These small chips, your left hand should give resistance to go beyond the sphincter. You should fix it. Yeah. Small pieces you have to cut at the Veru. You agree, sir?
Yeah, I agree. Highly technical. Apical resection is the highly technical.
Highly technically demanding.
You cannot allow bottleneck obstruction. You should not allow incontinence also. In between, you have to play.
Sir, one tricky question I will ask. when you go cystoscopy, when you do TUR instrument, if lot of pus flakes are there on the floor, floating, white mug, is on catheter or not catheter, diabetic, old patient. Will you wash before doing TURP? Will you clean it and so that better? Will you give antibiotic? What will you do, sir?
Antibiotic prophylaxis is a must.
Must.
Just before starting. Always
What
I give,
antibiotic you will give, sir?
I commonly give amikacin only. If RFK
Only
is normal.
amikacin.
Mainly
I give ceftriaxone, sulbactam,
Yeah.
no amikacin. You
No,
give only amikacin.
in some cases I add that, but amikacin is more than sufficient in my cases.
One
But-
antibiotic, that's all.
That's all.
So
Okay.
evening,
Yeah. Pardon?
evening.
Yeah, the same thing I'll
Amikacin.
follow.
Next day morning amikacin.
Also, when they are discharged, I'll give them
Did
more.
you use gentamicin any time previously?
No, gentamicin earlier I used to do 160 mg.
But now amikacin only
Amikacin
antibiotic.
is my favorite.
Only antibiotic.
Only antibiotic.
Oh my God.
And the situation you told, I always definitely believe in doing good bladder wash. Take out all that muck. In such a case, there will be multiple abscesses inside the prostate. So in such cases.
Sir, when you cut multiple abscesses coming, your principles of surgery will not change. Because when multiple abscesses come, they don't bleed. They will cut like butter. Yeah. Still you go to the capsule, sir?
Yeah, definitely I'll go to multiple abscesses. But in a frank abscess, prostatic abscess, I don't do that. I only just at the veru. I just make an opening. All pus will start coming down both sides. Just proximal to veru. Most of the times we can open the prostatic abscess there only. Nothing. I will not go to the bladder neck. Nowhere. Just remove all the pus and come out. No
sir,
resection.
I will ask you a very tough question, sir. Very tough question.
Please.
When you go inside, you see that prostate is there, moderate gland. Your scope, TURP scope, because of the suspensory ligament, not reaching the anterior bladder neck at all. You are just reaching the below the bladder neck. Or sometimes you are in the mid prostate, not reached the bladder also. Very tough situation, sir. Especially in obese patient, especially in suspensory ligament very tight. What will you do, sir?
Yeah, I will ask the anesthetic to elevate the little table up. Okay. And try to see the abscess. But hardly I come across.
Is there any logistics of bladder emptying, sir?
Yeah, always we keep half-filled bladder.
Will you press the above to reach the
I will. My nurse will be watching my bladder.
Okay.
My nurse will be watching. She tells me.
People say in obese patients when you have prostate,
very difficult.
Be careful before you take. Very obese, 140 kg patient, irritative symptoms more. They say that be careful about TURP. Do you agree, sir?
Yeah, definitely. Obese patients, for anything, they are high-risk patients.
High-risk patient. Sir, when will you go for, you have gone inside, you have seen TURP versus bladder neck incision. Your mind says, no, for this small gland, I don't want to do TURP. I will nicely cut and leave it. Let God say, I will not do anything. When will you do TUIP, sir?
The small glands, less than 30 grams. I still prefer young patient, small gland. If there is little bit internal tissue, I may little remove it. Otherwise, incision is more than sufficient, especially in young patients. That has given good results.
Sir, I must say that today, 250 people online.
Thank you.
Ratkal, sir. 250 generally goes for PCNL talks. Now, one person asked a question. I have to give respect. Is it good to practice apical enucleation with loop than a resection by marking mucosal incision at the level of veru and scooping out gland to give good clearance. He is asking, first you mark and make a cut, or you cut normal TURP. Sometimes we mark and decide. He is asking whether to marking before at the level of Veru is good or not. Ratkal sir. Shit.
Hello, sorry.
Yes, sir.
There is some problem there.
Yes,
Internet.
sir. If the Veru beyond tumor, the prostate is there, somebody is asking, marking all around before TURP is better, or just do normal TURP?
Definitely marking is a good practice, but I don't do that practice.
Even I don't do
Definitely,
that.
I'll have good mental picture of the gland, apical gland, and I go very slowly in that area. That's all.
Yes.
I don't do any enucleation.
Going slowly, going with a smaller scope, going with small chips, controlled movement, the sheath outside in is very important.
Because, see, one more point as far as what he mentions, no, enucleating that apical. See,
Sir,
by enucleating that apical, you may give a stretch on the sphincter. That
sir,
itself may cause the incontinence.
yeah.
I think that is not a good practice as far as.
Yes, sir. Sir, one more thing. In a case of large gland, if the penis is small preoperatively, will you put Foley's catheter for 1 week and then do the
No,
surgery?
I have not practiced these things. Never.
Sir, I feel, sir, if the surgery is more than 100 gland size, sir, sorry to say, sir,
It's okay, no
in
problem.
children, I want to express my view.
Correct.
In children,
Please.
in children and infants, when I do RIRS, sorry to interrupt you, sir.
No problem.
In infants, when I do RIRS, 1 day prior, I will put infant feeding tube, sir.
100% I agree with this point.
Yes, sir. Because access sheath damage of the urethra in infants is disaster.
Yeah.
Similarly, if the penis is small and grand is one bundle, I will put before the day night 18 French catheter so that next day thoda urethra is supple, so that it admits 24, 26 easily. You might have not practiced. I am expressing my view.
That is a good practice. I totally agree with you.
Sir.
Because, see, most of the patients will not have any patience for such things. But definitely, if a catheterized patient, acute retention patient, at least 48 hours if you have patient on catheter,
yes,
and
sir.
our resection will be much better.
Much
less
better.
Complications.
Much better with less complications. So if the patient can be convinced, put a 6-18, but it will become 22. Your scope goes easily. Your movements are easy. Your Zelocan jelly works well. Stricture will not form. You are happy. Especially, sorry dear friends, I use in enucleation, if I am practicing from more than 100 grams gland, if the penis is small in my examination, I will put Foley's catheter 1 day before. I beg pardon that I will request the patient that don't worry, 1 day you bear with a bit of it. Anyway, it's a subject of controversy.
No.
Next,
no, Chandramohan. What do you do in RIRS? If you are narrator?
Stenting.
Yeah.
Same
principle.
Same principle.
Urethra is not different.
Yeah. Yes, sir. Yes, sir. Thank you very much. Sir, one more question. People are asking, if the patient has a large gland, if the patient has a median lobe, if the patient has post-void residual in high, with only complaints of urgency frequency, if they come for TURP, will you do? I will do, sir. What you do, sir?
I will do.
Large gland, median lobe, urgency frequency, I feel they are very improved, sir.
Yeah. See, in a situation like this, counseling the patient is the most important thing.
Sir.
Again, see, there are absolute indications for TURP.
Sir.
Retention,
stone,
refractory retention,
stone,
recurrent hematuria,
stone,
recurrent UTI,
yes, sir,
upper tract changes,
yes,
and
sir,
stone formation. These
yes,
are
sir,
absolute indications for TURP.
Textbook answer.
Yes. Other things, relative indications. He comes under relative indications. Definitely, urgency frequency because of there may be subclinical infection. Big gland is there, big medial lobe is there. He will have very good relief. Only
Yes, sir.
counseling the patient about all the complications and doing, he should accept the complications of post-TRP.
Sir, I feel if the median low person comes for second time with problems, I will do TURP, sir.
That is the best practice. I
Best
agree with that.
practice.
Because
So
median
everything
lobe will not respond for medical enough treatment.
6 months you give treatment, next time he is coming, I am having frequency urgency also, I will do TURP.
It is only
90% they are improving.
it is totally to psychologically prepare them, give them for medical treatment for some time.
At least you can give mirabegron, sulfasalazine after TURP more confidence.
Yeah, they will be more comfortable.
More comfortable. See,
I agree with
these
this.
are all
These are the
individual
important points,
experience.
which has to be learnt long way.
By experience.
Yes,
You are
yes.
38 years, I am 22 years. People are watching maybe 5 years or 10 years.
No,
Every
there will be
patient
people,
will teach you a
even seniors
lesson.
also may be there.
Yeah, Kirpakar sir, I told to give this topic. He delayed. He is 40 years in the field.
Yeah, more than that.
Like you in Bangalore, I'm telling you, Victoria Hospital, before when I got married, they asked, are you the same department like Ratkal sir? No, when I was getting married, I was asked by my mother-in-law, are you the same department like Ratkal sir? Today, I am interviewing you. It's my fortunate day. That's a different issue. But that is the, see, there are two parts in this. One is expertise, another is science. Expertise is also as much important as science. If you have faced 1,000 TURPs, what is your gut feeling also matter. That is the aim of pure urology. Now coming to the last part of discussion.
One point I'll tell you.
Sir.
Because my practice started with open prostatectomy.
Sir.
Still I love that technique.
Yes, sir.
Because in very big glands,
sir,
still I love, my heart says, why don't you do open? Because
yes,
you are safeguarding the urethra.
Yeah.
There's nothing like that. How this robotic enucleation has come now.
Yeah. No doubt, sir.
Sir, it is nothing but open prostatectomy.
If somebody has practiced for 30 years open prostatectomy, millions and other, we have not seen. I have not done. I have done robotic. I have not done open because I have not seen. They will put finger. I have not seen at all. I have not seen.
It is a pleasure to do big prostates, open prostatectomy. Within
So
45 minutes, you are
finished.
finished.
For us also not to damage the urethra.
Correct.
If a junior sees 150 grams, if he feels that he cannot do it, leave it. Leave it. Put a catheter and leave it for 5 years. After 5 years, you will get experience. You will do better than seniors. But in the beginning, leave it. Put a catheter, refer to senior, close your eyes. If you want to learn, go to the senior, see how he does. TURP, enucleation, robotic prostatectomy, all are good. But don't take it ego, do only 10%. Patient will have irritative symptoms more. What do you say, sir?
Yeah.
Large gland juniors, more than 150 grams, your first year, second year, post private practice, leave it. Don't worry about the money earning. Leave it. Put catheter and send to senior, go there and learn. Because in your PG time, you might have not done that.
What do you call the senior during that case?
Yes.
You know, let him come from the back door and do and go. Let
your senior do it in your hospital and you earn money. That's a different issue. Yes. That's war for it. But you don't do it experimental. Yes. Because urethra damages, prostate bleeds, postoperative bleeding may be there. It can lead to severe problems, including morbidity and mortality. Now, coming to the...
And worst curse is incontinence.
Yeah, incontinence. You don't know in a hurry where you cut. Yeah. You may cut beyond Veru. Suddenly one cut beyond Veru in the anterior region, entire sphincter damages. You have not removed prostate, but you are creating leak. That patient will not leave you. Yeah. They curse you throughout life. And you cannot do TURP again because leak will worsen. So, dear friends, juniors, the ultimate aim of pure urology is that where to stop. Even for my level, his level, sir level, sometimes when things go worse, we stop. We put a catheter and come out, nothing will happen. But without vision, if you do cut and here and there, you may do trauma. What do you say, sir?
Yeah, I agree. There was also while teaching, I never done it. You can do one gland and come out.
Yes, sir.
After a week, you can go for second other gland.
Yeah.
One lobe we do, other lobe
Yes,
we can do after. But I have never done it. But people used to say that.
one person I told Dr. C.S. Ratkal sir is one of the great urologists in Bangalore, Center of Ratkal Specialist Hospital in Kangeri satellite team. Good. Anyway, sir, I want to ask you, in the post-operative period, when you put a Foley's and irrigate, suddenly bladder distends and irrigation is stopped. How to manage, sir? Don't think I am asking you basic questions. We want to listen you from a senior. Don't think that I'm asking like an examiner. Please.
No.
This is a thousands of.
Because they should learn it.
They should learn, sir.
Yeah.
This is what we have to give to next generation.
Correct. See,
Yes,
sometimes you must have left some small chip.
Yes, sir.
It might have blocked the catheter.
Yeah.
You have to give a wash and see. If it wash is not going well, you change the catheter immediately.
Yes,
if
sir.
there is a bleeding and clot, you try to reduce the BP of the patient, try to give more wash. If it is not, immediately take to the theater and look in what is best you can do, you do.
My dear friends, sir said in the last, immediately take inside the theater and look. Never ever hesitate to take in the theater. Don't think that patient attendants will feel bad. Don't think that it will cost money. No, you are unnecessarily will be in trouble in the night. Your energy is wasted, patient energy is wasted, attendance energy is wasted, fluids are wasted. Go in, evacuate and come out, it will stop. What do you say, sir?
It will stop.
It will stop. Just evacuate like a leak evacuation.
So,
finish the clot evacuation, it will stop. Because God has created coagulation. What do you say, sir?
Yeah, I agree. I have done many times. That only just evacuate the clots, bleeding will stop, patient will be fine. Evacuate, patient will be fine. After that, God knows whether you have left gland, whether you have left anything, but temporarily mortality and morbidity will be zeroed. You can sleep happily. Evacuate the clot because clots will not come out of the small 22 French catheter. Never.
No. What do you say, sir?
Yeah, you must always sheath wash.
Yeah. Sir, last two questions, sir.
Please.
When will you remove the Foley's catheter? Now and 1990?
Yeah. See, always my practice is 48 hours. But in between, there is a paper from All India Institute of Medical Science, 24 hours.
I never did it.
Sometimes I practiced that, but I'm not very happy.
Not very happy.
My practice is 48 hours.
I do for 3 days, 72 hours. Now I am slowly, after 20 years, I am coming to 48 hours. In India, they pay you package. If you keep 3 days or 4 days, they will be happy.
They don't mind.
If you discharge early and they don't pass, they will curse you.
True.
So, God's sake, don't be crazy about removing the Foley's catheter.
Yeah.
Nobody in India is so busy that 2-3 days also they cannot spend. We VIPs, they happily relax. You don't take stress of removing on the same day or next day. Inflammation, mucosa cutting, always create some pain. They may not pass, they will not be happy. So, what do you say, sir?
Yeah, I agree. While removing catheter, I always counsel my patient.
Yes, sir.
One is incontinence.
Yes, sir.
Incontinence are both stress and also urgency.
Yes, sir.
Second thing is bleeding. You may pass some blood in the urine.
Yes, sir.
Some burning, dysuria will be there.
Yes, sir.
You should not stain at the stool.
Yes, sir.
And last thing is, sometimes you may go for retention also.
Yeah.
So, you may need catheter because this is a big size catheter. I can't keep it for longer time.
Yeah.
I have to remove it 48 hours. If I keep longer time, it will cause harm to the urethra. That's why I'm removing it. If you develop retention, I'll again put you back on smaller catheter. You go home, come back after 1 week, remove catheter. That's all. Most of the patients, 99% of the patients, they pass urine after 1 week.
Sir, I am asking you very important question asked by many people in the chat box. Aspirin, clopidogrel. How many days you stop? When will you start?
5 days before.
I also stop 4 to 5 days. No compromise.
And immediately after removing catheter or after 24 hours. My cardiologist says you can start 24 hours. I usually start even after 24 hours.
I will start after 3 days of catheter removal because I am always worried for bleeding. But if the patient is very coronary artery disease prone, as sir said, start, because that is also important. Heart is also important.
More
Prostate
important.
is also important. So
Heart
your
is more
voiding is
important.
also important. Your bleeding is also important. Heart is also important. But I feel personally that 1 or 2 days doesn't matter. Don't be in a hurry to produce bleeding. Bleeding management in post-op is headache. What do you say, sir?
Yes, definitely.
It is a big headache.
It is very difficult to.
Very difficult, especially prostatic fossa. When you go inside after TURP, oh, everything will be red. What do you say, sir?
What they say is probably he has not done a good surgery.
Yeah. If you are bleeding means you are not done good surgery. Especially if you go inside again, don't try to see the fossa too much. Clot evacuation.
Not at all. Not at all. I agree
If
with
you
this point.
resect, you will have more problem.
In my 30 years, and hardly I have coagulated.
Yeah. So just evacuate the clot and come out. By the time coagulation process is done.
Nice. I agree totally.
Now,
hemostasis is achieved.
So with this, we have spent an hour of time. I must thank Ratkal sir for accepting. He is the one person who has seen. He accepted that for 1,000 rupees, 1,500 rupees, TURP is done. So dear juniors, when you are, he said one more thing. When you are learning, waive off the money. Take it for granted. In Indian circumstances, having a patient for learning itself is a rare thing. In future, it will be much more rare. So when you are experimenting, don't expect money. Do well. Take the senior. Pay him. Learn. One day or another day, you will also become Ratkal. You will also become Chandramohan or XYZ. That day, you be happy doing surgeries. But in the beginning period, be careful. All these talks are to encourage you to do safely. Patient should not die. Patient should not get bleeding. Patient should not be taken into the theater again. For that discussion, sir has sent me 5-6 videos. I told sir, no videos, sir. Everybody will show videos. This discussion of 1 hour, wholeheartedly, sir has mentioned that how he managed post-op, how he has charged, how the water is used, how the small size, big size are used. These type of sharing knowledge should be appreciated. From my heart, I will say that this is one of the best interaction I have done in the recent past. I thank you, Dr. Ratkal sir, for being with us for 1 hour in this most common bread and butter surgery. URSL and TURP, dear juniors, you should become master. No chance to do mistake. I tell all my fellows, TURP, URSL, no mistake. No ureteric perforation, no ureteric avulsion, no severe clot formation, no incontinence. Thank you, Ratkal sir, for your excellent insight into the TURP.
I thank you and also ASU Council for giving me this opportunity to express myself, my experience. If it is useful to the juniors, I am more happy.
Thank you, sir. Thank you very much. Though it is not ASU Council, I am secretary of the ASU. ASU also, see, sir, 309 people.
No. On behalf of a council, you are there.
Yes, sir. Yes, sir. 309 people are watching, sir.
Oh,
it
nice.
is a conference. It is like a conference.
So nice.
Thank you, sir. Thank you very much.
I feel privileged. Okay.
Thank you very much.
Chandramohan.
Thank you.
It was a very good discussion.
Thank you, sir.